Hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. Today's webinar is titled An Introduction to Social Pediatrics and the Role of Education in the Health of Children and Youth. And this is actually part one of a three-part series on social pediatrics. Social pediatrics has certainly been a topic of interest for the CAFC audience for quite a number of years, bringing sessions to the CAFC annual conference more than once, most recently at our last CAFC annual conference in Toronto in 2013. We had a very exciting session partnership with the Pediatric Chairs of Canada and the Canadian Child and Youth Health Coalition. And thanks to the leadership of Dr. Dennis Danneman of Sick Kids, we've decided to bring this as a series to our CAFC Presents audience. So we're very excited to do that. As always, we will take your questions at various times throughout the webinar, so I encourage you to type your questions into the box as you think of them so that we have the questions ready when it's time to present them to our panel. You're free to come and go from the session. It doesn't interrupt the session, and we do record the entire webinar so that you can always go back to the recording to catch up on any parts that you might have missed, or to share the recording of this session with your colleagues. The recording and any other resources or documents that may be provided to us by our presenters will be posted on the CAFC Knowledge Exchange Network. And it usually takes me a couple of days to get that information up, and you will receive an automated message from the system with a direct link to the page, although you can always use the search function on the CAN to find the information as well. The Knowledge Exchange Network also provides an opportunity for comments for registered users. Anyone can register for an account on the Knowledge Exchange Network that would allow you to post comments at the bottom of the page. And we encourage you to continue the discussion following this presentation if you're interested, or post any other information or links that you think would be of interest and related to this topic. So without any further ado, it's my pleasure to introduce our speakers. Sort of our co-host for this ongoing series is Dr. Dennis Danneman, and he's currently a professor of pediatrics and chair of the Department of Pediatrics at the University of Toronto Faculty of Medicine. He's also the pediatrician-in-chief at the Hospital for Sick Children and the R.S. McLaughlin Foundation Chair in Pediatrics at Sick Kids. And his clinical research relates to the care and outcomes of children with diabetes and other endocrine disorders of childhood. And joining him also from the Toronto area is Dr. Arjaman Siddiqui, and she is currently an assistant professor at the University of Toronto Dalla Lana School of Public Health, and also an adjunct assistant professor at the University of North Carolina in Chapel Hill. Dr. Siddiqui is interested in the role that societal conditions play in shaping inequities in population health and human development. In particular, her research utilizes a cross-national comparative perspective to understand the consequences of social welfare policies for inequalities in health and developmental outcomes. And also joining them is Dr. Mariam Mehtar, whose name may be familiar to the CAFC audience, in that she has presented at the CAFC conference a few times over the past few years. And she's currently an assistant professor in the Department of Pediatrics at the University of Saskatchewan. And she's the director of the Division of Social Pediatrics and Pediatric School-Based Health Program in Saskatoon. And she's also the program director for the Pediatric Residency Program at the University of Saskatchewan. So it's now my pleasure to hand the virtual podium over to Dr. Dennis Danneman to kick off this series. Over to you, Dr. Danneman.
I take it you can all see my screen now, which says An Introduction to Social Pediatrics, a webinar in 3 movements sponsored by PCC and CAFC, with me as the director and Doug as the producer. I actually wanted to play Crosby, Stills, Nash & Young's Teach Your Children as a way to start this one off, because this one is an introduction to social pediatrics and the role of education in the health of children and youth. I think many of you have probably read a little bit of my rant that was a call to action as to why we were doing this. It seems as though, for some reason, child health and child well-being has not made it onto the radar of either the federal or provincial governments as a major feature or central point in their health policy and health care development. And it seems to me that there are a whole host of reasons to do this. Besides the typical statement that the children are our future, which is obvious, it's clear that Canada doesn't do quite as well as it should, or anywhere near as well as it should, when it's held up against many of the other rich countries around the world, either by the OECD ratings or by the UNICEF ratings. And the UNICEF 11th report that came out last year put us flat, number 17 out of 29 of the wealthiest countries in the world. Now, there are many things that one can discuss about that, and we'll come up with some of those a little bit later. So The first one is the introduction to social pediatrics and the focus on education as the mediator of health outcomes. I'm going to make a few introductory remarks about social pediatrics, and then Arjumand will talk about the relationship of education to health outcomes, and I can think of no one better in Canada at this point in time to do that. And then Mariam is going to talk about the school as an opportunity for providing healthcare to vulnerable populations. Arjumand and I are connected to our relationship to the University of Toronto, and Mariam and I went to the same medical school a number of years apart. The University of the Witwatersrand, which means the Hill of White Water, the gold-bearing reef that runs under Johannesburg. The second webinar, which will be in 2 weeks' time, will be the Paediatrician as Child Advocate and Child Protection, with Lee Ford Jones providing introduction, and Jean Clinton and Sue Bennett providing the meat of the presentation. Jean speaking about leveling the playing field, and Sue about when is the child at risk. And finally, on the 9th of April, we'll be talking about vulnerable populations, Aboriginal children with Mike Moffat, inner city youth, person still to be confirmed, and then John Wittenberg will talk about developing a child health curriculum in social pediatrics. So let's get to some of the definitions here. This is a personal definition because you can find a whole host of definitions of social pediatrics, but let me give you mine. It refers simply to the health and well-being of children, most specifically those living at the margins of our society, disadvantaged, disabled, dispossessed, or disposed of, if you will. This description hinges very much on our recognition of the social determinants of health as critical mediators of outcomes in children. Now, I have to say, personally, quite frankly, we use the term social pediatrics all the time. We write about social pediatrics all the time, but it is in fact quite an unfortunate term because it suggests that social pediatrics is the exclusive domain of those of us pediatric healthcare professionals rather than society at large. And we want to give the impression that that's not the case and that this is a societal at large issue and everybody's involved in the health and well-being of children, not just pediatric healthcare professionals. That's a very important lesson number one. So are we being pedantic, or is there a real reason for changing the name from pediatrics to child health and well-being? And I think we're not being pedantic at all, and the real reason is that pediatrics really is about the care of sick children, and in fact the care of the sickest children. It tends to be the medical model to be MD-centric. It tends to occur in pediatric academic health science centers where children are getting exquisite care across the country, to a lesser extent in community hospitals and in the doctor's office to a lesser extent. Child health and well-being is about ensuring the health and well-being of our children, which occurs everywhere. It's the community, it's the school, it involves all the powers that be, and most importantly, it is interdisciplinary or a sociological model rather than a medical-centric model. It involves health policy, early child evaluation, supporting the social security net, and dealing with the leading issues in child health such as mental health, and mental health gets short shrift in many places. It also has to do with global health, the global to local and local to global, and it has a big deal to do with advocacy, and I'll come to that as we progress. So I want to make a couple of essential caveats. Child health and well-being do not occur in isolation. The child inevitably does not live in a vacuum, but they live in the context of their family or another sort of social situation, if you will. And maternal health becomes an absolutely essential part of child health and well-being. And not focusing on the mother as well puts the whole system at risk, in my opinion. Secondly, the mother and child do not exist in a vacuum at all. They live in a community and a society, and so community health and societal health are absolutely important as well. And income inequality, the presence or absence of a social safety security net, and other such factors are very important indeed. And I'm going to spend a little time on income inequality. But I think one of the things that has happened in Canada over the last number of years is, after having a very nice and tight social security safety net, it's become a little more than slightly porous. And I think that's what's happened in leading to our rather poor performance in many of these indicators. Child health and well-being encompasses a whole variety of different aspects, identifying the children and their at-risk, their vulnerabilities, mitigating those through health maintenance, disease prevention, early childhood experiences, early diagnoses, and the need to navigate the healthcare system. We have a healthcare system that's been reviewed recently in a couple of books, one by Jeffrey Simpson, another by Andre Picard, both of the Globe and Mail, and they both come up with similar conclusions that we have excellent hospitals, we pay for drugs, we pay for physicians very well indeed, but we don't have a navigation or coordination of the system that's led to some of the countries around the world improving in their healthcare system while ours remains relatively stuck in the middle. And one of the things that's very clear in those countries that have moved up the scale while we've remained relatively static is that healthcare reform, primary healthcare reform, has led to an improvement in their healthcare system, and child health is one aspect of that. So this has a whole lot of pictures that were meant to be there that I took off the web, but because of copyright issues, I'm not going to show them. But what it shows on the one corner is the window of opportunity. And there clearly is a window of opportunity that starts pre-pregnancy, goes through pregnancy, and into early childhood development. That's essential. It's not that it's the only time that there's a window of opportunity, but it's very clear that this is an essential period of time that's remarkably important in the hardwiring of the infant or the fetus and in their well-being as they appear to the world. The Barker hypothesis talks about in utero programming of chronic disease and states that many human fetuses have to adapt to a limited supply of nutrients, and this is true in many parts of the world, and in doing so they permanently change their structure and metabolism, epigenetics if you will. And these changes may be the origins of a large number of diseases that occur later in life. This is another reason why the healthcare system should be paying attention to the unborn and the newborn child, because they have the ability to alter things in a way that will decrease adult diseases such as coronary heart disease, related disorders such as stroke, diabetes, and hypertension. Very, very, very important indeed. I want to just stop very quickly for a second on attachment theory, and that's Bowlby, who enunciated the theory in 1969. I thought it would go much further back than that, but when looking at attachment theory, it really is something that's only relatively recent in the mindset. And this is the ability of children and adults to have attachments and trusting relationships that allow them to navigate their way through life in a much better way. Those children's secure attachments allow them to separate and then come back to their parents when they're frightened. Their parents, when they appear, are met with positive emotions, and they prefer their parents to strangers, edging out of their parents, if you will, umbrella over time and being able to stand on their own 2 feet, allowing them as adults who have secure attachments to have trusting, lasting relationships, good self-esteem, comfortable with friends and partners, and seeking out social support. So when you have abnormalities in early childhood development, or somewhere along the way you get maladaptation and maldevelopment of these secure attachments, which lead to a whole variety of mental health issues and difficulty dealing with society at large. So you go from secure to preoccupied and fearful and a whole variety of others. And as we as healthcare professionals deal with children and their families, we should be mindful of how our interaction needs to fit into this whole secure attachment theory. One more issue of note is that the Flynn effect suggests that on average the IQ scores have been, over the last number of generations, have been increasing. There is a little suggestion that they're plateauing and may in fact be not only plateauing but heading in a downward direction because of the stresses and strains in many parts of the world. This is IQ overall, but also semantic and episodic memory. The exact causes are unknown, but must, in my view, be related in some way to better nutrition, better education, better healthcare in general. So a very big multitude of different factors, but very much linked into the social determinants of health. And this suggests that as the IQs have been going up, it's both a factor of nature and nurture. But I took that from the web. Okay. So here is just one outcome which I think is worthwhile looking at. The probability of the child developing overweight or obesity over their lifetime depended on a number of risk factors, such as did the mother smoke or not during pregnancy? What was the gestational weight gain? Did she breastfeed or not? And as a newborn and an infant, did the child sleep more or less than 12 hours a night? And as you go from good outcomes in all of those, in other words, no smoking, appropriate weight gain, long breastfeeding, and good sleep patterns, you have a probability of about 6% of children with overweight and obesity. And as you add in one of these factors at a time in a negative way, you go up to 10 to 12. When you add in 2, you go to 13, 17, 20%. And when you have all 4, you're up at 30%, which is where we are in Canada as you look at the teenage and young adult population. Almost 30% of them are overweight or obese. So we need to take those into account and look at them very clearly. And childhood obesity is clearly due to a multitude of factors. If you look at one factor alone, namely the duration of breastfeeding, what this slide shows is that for every month of exclusive breastfeeding that the child is exposed to, there's about a 5% lesser risk of developing childhood obesity and overweight than not having breast milk. And this is very, very, very important. And at least some of the provinces recognize this and are introducing campaigns to improve breastfeeding. So let's deal with what I call splat in the middle, and UNICEF Canada calls stuck in the middle. The IRC 11, the Infante Research Consultation of 2011 that came out from UNICEF. And here we are, number 17 out of 29 of the richest countries in the world. You'll see at the very top are the Scandinavian countries, relatively small countries and smallish population, Netherlands, Iceland, which had no economy just a few years ago, as opposed to Canada, which continues to have a pretty vibrant economy, is number 3. Canada is number 17, and the United States is number 26. Only Lithuania, Latvia, and Romania are lower than the United States. That's a pretty awful place to be. So UNICEF Canada put this out and as a way of trying to encourage us to put children first, and said we need to have information, we need to know what's going on from year to year, and we actually need to establish a National Children's Commissioner, something that was introduced as a private member's motion in Parliament by Mark Garneau about a year ago and was voted down. I think that's a pity, but we'll keep going back and supporting that. So let's go through a few of the things that tell us where Canada sits. Here, dimension number 1 is material well-being with many different factors. And if you're looking for splat in the middle, here it is. Canada is right in the middle. If you're looking at relative child poverty rates, and this is the percentage of children under 17 years of age who live in households who are below the 50th percentile of the national median. You could say this varies from country to country, and it may not be so low in Canada, but if you ask the families, they tell you they're living in poverty relative to the rest of society. And we're sitting here right between the middle and the lowest tertile. Not a good place to be. So it's clear that children are living in poverty in Canada. 13% of households, children live in poverty, and this is something that clearly is going to have a major mitigating factor in leading to poorer health outcomes. Here's one in which the UNICEF indicators are quite inconsistent. Infant mortality rates in Canada again sit between the middle and lowest percentiles at 5.1 per 1,000 live births. On the other hand, low birth weight sits between the upper and the middle tertile and is in, if you will, the better range. And this is inconsistent because infant mortality rates and low birth weights sort of hang their hat on similar features. And so one has to look very critically at this. And Professor Joseph and others through the University of British Columbia and the neonatal health networks have looked at this and published a paper in 2012 in the BMJ, and I'm going to share a little bit of the results to suggest that the data as they relate to Canadian outcomes might be incorrect. So here in the top slide, on the bottom part of the live birth, less than 500 grams per 10,000 live births, and you can see Canada and the United States report about 11 and 14.5% respectively. All the other countries report less. And when you look at the infant mortality rate per 1,000 births, they're very much related to the frequency with which we report births under 500 grams. When you take out births under 1,000 grams, it in fact becomes a straight line, and Canada and the US are no different statistically than all the other countries in the world. So this measure, at least, it's still a relatively crude measure, doesn't tell the truth, the whole truth, and nothing but the truth. It says that we're resuscitating children of very low birth weight, of very early gestational age, and other countries are not counting those as live births and accounting for them in infant mortality rate. So I think we have to be very careful. And this is a political hot potato, if you will. Here is another potential hot potato, immunization rates, where Canada sits right flat at the very bottom, together with Austria, with under 85%. And the reasons for this are not known. It might be that we have a pseudo-sophisticated population that thinks immunization is bad for them, that it's damaging. We may have a population that's never been exposed to the diseases for which immunization is given and therefore have benefited by the herd effect and therefore don't think it's for them. But it's very worrisome to be with the bottom. As you go to the right side, you see that Canada, on the Program for International Student Achievement, that student achievement by age 15 is way, way, way at the top, just under Finland. So we're kind of a little bit spotty in our outcomes here. So what is the reason for our showing? There may be some reporting bias as it relates to infant mortality. There may be some different ways people are measuring things, but we shouldn't push these findings aside and say it's wrong. Is it inadequate spending on healthcare? I don't think so. I think it's inadequate distribution of our spending on healthcare. Is it inadequate physician supply? Certainly there are parts of the country in which the physician supply is very low, but overall I don't think this is it. I think most of them are related to the social determinants of health and are listed here. Inadequate attention to public health, balance between the size of our country and supply of resources, a flimsy and ever increasingly porous social security net, inequities particularly in income, and the fact that we're a large immigrant refugee population which is very ethnically diverse, and this is not being given the attention it deserves. So here are a few slides taken from Richard Wilkinson and Kate Pickett's book, The Spirit Level, written in 2009. And here is on the bottom axis, national income per person from 0 to 40,000 US dollar equivalents per year. And here is life expectancy in years at the time of birth. And you can see as you get onto the plateau at the top here, it's no different in Costa Rica from the United States or Norway. So from $10,000 per person per year to 40,000, it doesn't make a difference, except in those countries in sub-Saharan Africa like Namibia, South Africa, and others that were ravaged by AIDS. But there's clearly a significant incline as you go from 0 to 10,000 per person per year. Daniel Kahneman, who wrote that brilliant book, Thinking Fast and Slow, did a study in which he looked at happiness quotients and found that people had a steep rise in their happiness as they went from 0 to $75,000 family income per year, and then it plateaued after that. So after $75,000 a year, you're able to suffer in comfort, but it doesn't make you any happier. And when you look at income inequality, which is the discrepancy between the highest 20% income earners in society and the lowest 20% income earners in society, there's clearly a hierarchy of lowering or worsening of the index of health and social problems in adults as you go from the more equal to the less equal countries. So the US is clearly the worst outlier here, but there are many countries along the way, and Canada is always flat in the middle, and Scandinavia is always at the bottom here, and Japan's also quite at the bottom there. When you apply the UNICEF Index of Child Well-Being, so now better is at the top and worse is at the bottom, it looks much the same, with the US and some other countries doing very poorly in outcomes because they have the highest degrees of income inequality. There are a whole lot of countries that are very close to each other in the middle, and then again Scandinavia does quite well at the top. Japan, for some reason, has low income inequality but doesn't do so well with its children over there. So I think I'm about at the end of my 20 minutes, and I just want to summarize what I think about child health and well-being. Many of us work in the realm of tertiary and quaternary healthcare centers over here, the red line over here, which could be called the pediatric or child health ivory towers, where we're trying to push back the frontiers of healthcare as much as we possibly can. There have been spectacular gains over the last many years. From when I started in pediatrics more than 35 years ago to now, the longevity of children with cystic fibrosis has gone from the early teens to the late 40s and maybe early 50s. Acute lymphoblastic leukemia has gone from being almost uniformly fatal to being rarely fatal, if you will, and many other conditions. But we're only treating a few children with the most severe and, if you will, rare conditions in these sorts of environments, and this medical model over here. But most of the children are getting the support for their health and well-being is in this direction over here, which increasingly becomes a sociological model. Some secondary care occurs in the academic health science centers, much of it in secondary care, but it's the primary care public health issue that becomes very important indeed. And I had them in the same circle over here, or egg-shaped structure, if you will, but then I put this lightning rod in the middle here because I see primary care and public health as being separated by something very fundamental. Primary care, like the secondary tertiary care, is about individual rights, the right of each of us to receive the best possible care and the best possible outcome, whereas public health is about the common good. And it's sometimes very difficult for healthcare professionals who are functioning on this part of the lightning rod to move into this part, and the public health to move into this part, if you will. And that's where the dilemmas of child advocacy occur. In social determinants of health play increasing roles as we go in this direction, and I think child advocacy involves inevitably all of us equally. So I'm going to stop over there and hand over to Arjun Siddiqui, who was given a very good description by Doug Maynard, and will be talking about the aspects of how one's health leads to how one's educational health has impact on one's physical health. Arjun, it's all yours.
Thank you so much, Dennis, and thanks everyone. Thanks for having me. It's really nice to be able to talk to everybody, and my presentation really dovetails very well on the things that Dennis has said, and I'll try to integrate some of Dennis's thoughts into mine as well. So the focus of my presentation today is the relationship between education and child health. In other words, education is sort of a determinant of child health. And what I've done is categorize that sort of overall notion into three parts. And those three parts are largely based on the kinds of literature that we see, the ideas that are being produced. And again, they very much relate to what Dennis said. And the first is that parental education, or parental socioeconomic status, is what we think of as a fundamental cause of child health. The second importance of education is that a child's own education is a determinant of their lifetime trajectories of health. So both parental education as well as one's own education seems to be a key player in health over the life course. And the third is a more provocative notion, which is that child education actually is a part of child health. And I'll get to that towards the end. So let's talk a little bit about how parental education is a fundamental cause of child health and what that means for it to be a fundamental cause. This is a slide from Canadian Council of Learning where they've nicely summarized some of the key findings about how parental education affects children's well-being. In the first bullet, you can see that they've shown that lower socioeconomic status, including lower parental education, is associated with heightened risk of emotional difficulties in kids. In the second bullet, they've shown that in relation to lower SES children, higher SES children, meaning those with parents who have more education, income, and so on, low SES children, are more likely to smoke, they're less likely to exercise, more likely to get infected by sexually transmitted diseases, and so on. Quite a wide variety of physical health outcomes in addition to emotional health outcomes that accrue to children with parents who have lower levels of education. And finally, Dennis sort of mentioned the very earliest years, which, as he said, we know are incredibly important. And what we're finding is that parents with lower socioeconomic status are also less likely to follow infant feeding recommendations and so on. So this is probably not very newsworthy for many of you, but what I thought would be helpful is to talk a little bit about why this happens, which often seems to be a point of contention or misunderstanding. And so what I've done here is just put education at the top, meaning sort of parents' education. And that could mean, let me go up a slide. That could mean things like their job conditions, their income, their neighborhood property tax base is another sort of metric that's tied to their education. So these are all sort of socioeconomic resources that are reflected by parents' education, meaning that parents' education may actually mark for these types of socioeconomic resources. And in the end, they seem to affect children's health by affecting children's activity levels, exposure to environmental pollutants, their nutrition, their stress levels, and even some epigenetic processes that we're learning about. And the key question is, why does that link manifest? And what we know is that that link is not primarily because of any sort of cultural traits that manifest in lower SES families, which tends to be a very common idea, but there's not very much empirical evidence to support it. In fact, what we think is happening is that families with lower education levels have home environments and parenting styles and so on that are a direct reflection of the kinds of stress levels, the kinds of sort of everyday lived experiences that parents are facing, and then sort of are manifest in the kinds of home environments that children are exposed to. So the first kind of idea is that education is a determinant of child health because parental education is a determinant of child health through these processes of the effects of education on your sort of everyday lived experiences and then those of your child. The second is that children's education is a determinant of their own lifetime health trajectories. This is a study from Amélie Cannell-Vallée at McGill, where she shows that if you look on the left-hand box, mother's education is a determinant of the respondent's or the child's socioeconomic position in adulthood, meaning that through the process of parental education, you actually see a translation. There's sort of a path dependency to what a child's education level will be, and that in turn influences the child's future risk of major depressive episodes. So there's an independent influence of parental education on major depressive episode, which we talked about earlier, and then sort of a separate effect on child's own chances of depression. And this is just a review article that demonstrates all the different outcomes that we know are linked to early education. So education sort of throughout the life course leads to health changes throughout the life course. So those with lower levels of education are in the future more likely to acquire diabetes, obesity, stroke, coronary heart disease, onto the next slide here, kidney disease, and so on. So there's quite a wide range of health outcomes that seem to be linked to education in children. And moreover, these tend to be the outcomes that account for the largest sources of mortality in adulthood and premature chronic conditions. So the first two propositions were relatively straightforward. First, that parental education affects children's health. The second, that children's education affects their future health. And the third, as I said, is a little bit more of a provocative notion, and that is that we might also think of children's education in the moment, not in the future, but in the moment during childhood, as actually being a component of their health and of their well-being. This slide is courtesy of my late great mentor, colleague, and friend Clyde Hertzman, and an idea that he and many others have sort of been working on for years, and that is that we may want to understand children's health and their well-being in a broader sense. That is, that it is certainly in part determined by thinking about their physical and sort of mental health outcomes, but that there is a broader set of developmental competencies that actually are a better way, particularly in the wealthy countries where we have lower levels of early child death, and our children en masse are sort of surviving longer, but perhaps not thriving as well as they could, that there is this larger set of constructs that we often don't deal with in primary care and, quite frankly, in public health either, that have to do with not just physical well-being, but communication skills, language and cognitive skills, emotional maturity, and social competence. That is, these are not about clinical endpoints per se. This is not about developmental delay per se, but this is about the kinds of resources people need to live good lives, if you will. And that education then, both as a setting, school as a setting, but also sort of language and cognitive and other skills as part of education is then integral to how to think about child health. And I don't have good empirical data for you to support this, because this actually isn't an empirically driven notion. I can show you lots of empirical data about how this matters for future health, just like education does. But this is actually a notion that we'd have to buy into. We would have to think that children's well-being extends far beyond their clinical outcomes. And if so, this is one conceptualization of the gamut of aspects of children's well-being that we might think about and care about. So let me move on to sort of saying a little bit about what Dennis started to talk about, which is that societal conditions seem to really matter in this equation. And part of the reason they matter is that the very reason family education and one's own education are tied to child health is because societal conditions create that tie. So a really straightforward example is that in the U.S., basic access to physicians and hospitals is determined by family SES, because so is health insurance, and so it's not universally provided as a matter of policy, and therefore you get these situations where family SES is directly tied to access to care. In Canada, that's less so. So we've used societal conditions, policies, to actually break the tie between family SES and access to basic child care. But in that same way, societal conditions, including in Canada, as Dennis pointed out, shape many other factors that contribute to child health and that contribute to family SES that extend well beyond the healthcare system. As part of the WHO Commission on Social Determinants of Health, we put together this framework which basically highlights the kinds of societal conditions and environments that influence children's well-being. You can see the individual child in the center there and different environments extending outwards. These boxes represent environments that aren't sort of geographically delimited, especially sort of early childhood services and programs being one. So the idea is that societal conditions matter for family socioeconomic status, and they matter for linking family socioeconomic status to child health and well-being. And so paying attention to those societal conditions actually is a really integral part of figuring out how to improve child health outcomes, particularly en masse. And so here's the sort of trillion-dollar question, which is how do we do this? And I think one of the key things that we think about in this field is the work of people like Jim Heckman, who many of you may know, who has done some economic analysis to show that early investment in children has much higher returns in the long run in terms of health, well-being, and all sorts of societal outcomes, decreases in crime rates, decreases in healthcare spending. There's really a huge gamut of outcomes that are offset in a life course through early investment, through investment in children, rather than investment later on, waiting till things have already kind of gotten bad and then investing in adults in whom much of the damage, unfortunately, has already been done. And so what he shows is that this huge benefit of reaching children early and advocating for policies that help children early is actually of huge societal benefit and a huge cost savings. So there's really many arguments that support this notion of caring about how societal conditions and social policies affect health. Everything from justice perspective to social sort of societal well-being to economic savings and back. I found this interesting diagram on the internet, which also kind of made me sort of think about Dennis's depiction of primary care and public health. And I thought this was actually a nice way to show how the two can be combined in creative ways and in important ways so that you're on sort of both sides of the lightning rod at the same time. And this depicts a pediatric health clinic that has a sort of founding premise that it's family-centered. And being family-centered then means that they provide not only care to children, but they also have a host of ancillary services that allow families and children to get the supports that they need in recognition of the fact that child health is really a function of this broader set of factors. So this is sort of a more concretized way of seeing how this can happen, not just through societal policies, but in day-to-day clinical practice. And I'll leave it there and hand it off to, I think, Mariam is next.
All right, thanks, Dr. Siddiqui. And that's, while we're switching over to Dr. Mehtar, we'll just remind the audience this is your chance to type in your questions so that we have them ready for the discussion at the end. So if anyone does have any questions, we can take a few questions while we're waiting for her to reconnect.
What I liked about your talk, Arjumand, was how you expanded on everything I said at a superficial level, and it really, that last slide brings it all together in the sort of community services one needs to try to conglomerate in the best way possible.
You know, and that wasn't even planned that we dovetailed so nicely. It shows how we think. Yeah, I thought that clinical example was particularly compelling. I work mostly, as you know, in the sort of domain of policy analysis, and so sometimes it's difficult for me to have a good response for what people can do on the ground, and I think this is actually a really stellar way to think about this because it incorporates all those sort of aspects of child well-being on the ground on a day-to-day basis and allows clinicians to have a really big part in that.
A question from Christina has come in, and she's asking if Dr. Siddiqui has considered how parents can negotiate child outcomes via their education. She has great work in social science exemplifying how parents, as a result of their education, can negotiate educational outcomes, and as she is beginning to find with her studies, health outcomes.
Yeah, that's a great question, and I don't do that work myself in any detailed way, but I know the literature a little bit, and you're absolutely right. I mean, I think parental education is a big component of this, and what I find really fascinating is that the reasons it's a big component have to do not only with parental knowledge per se, but the kinds of kind of life experiences and stressors or lack of stressors and job conditions and so on that come to people who have more education and therefore allow them to sort of design life sort of in a way that enables them to support their children's education a little bit better.
And she's also asking, have you published anything on this topic? Where would they find any of your papers?
I can actually make those available, maybe, Doug, through you?
Yeah, if you give me any links, if they're in any sort of online format, in any online journals or anything, just send them to me and we can put them on the page on the Knowledge Exchange Network.
Absolutely, I'll do that.
All right.
Thanks.
I believe that Mariam is now connected.
Yes.
I am back.
All right.
Thanks, and thanks for your patience. Being a pediatrician doesn't confer any technological skills, apparently. So I am going to talk about school as an opportunity to influence health, and what Dr. Dannemann and Dr. Siddiqui has spoken about before during this webinar really sets the stage for the context in which I practice pediatrics within schools. I just want to mention that there are some slides that I'm going to show, which comes from the Foster Care Alumni of America, their postcard project. So the objectives of the talk is to discuss the school environment as an environment which I practice pediatrics. I want to emphasize the collective role of individuals working in teams, and so it's not just about pediatrics. And then also just talk about schools as an alternate model of care, providing health care to infants, children, and youth. So I'm not going to belabor this because both Drs. Danneman and Dr. Siddiqui has gone through the determinants of health, but I do feel that I need to set the context for why we are in schools. So what determines health? We know that it is more than one's biology or genetic predisposition. What determines health really depends on the non-medical determinants of health. Income, housing, race, ethnicity, early childhood development, and education, amongst many others. And it is not only about where we live or how much money we make, or our level of education. What determines health, particularly in the Canadian context, is also whether you are of Aboriginal status or not. And so talking about the determinants of health, as Dr. Danneman had previously gone through them, it is the environment in which children play, in which they live, in which they grow. And these environments are essential in how kids grow up and will determine and influence influence their health. Early on in childhood, it's extremely important to understand that human development is shaped by dynamic and continuous interaction of biology and experience, and that human development is shaped by the ongoing interplay among sources of vulnerability and sources of resilience, and that the developing child remains vulnerable to risks, but also open to protective influences throughout the early years in their lives and into adulthood. And this is important because we talk a lot about early childhood development, but I think it's important to understand that we don't lose the opportunity later on, and particularly again within the context of schools, to help kids and to find those find resiliency within kids to overcome some of the adversity that they may have been exposed to. We know that growing up in poverty greatly increases the probability that a child will be exposed to environments and experiences that impose significant burdens on their well-being, and therefore this shifts the odds towards more adverse developmental outcomes. And this slide is one of the first of the postcards from the foster care alumni. We also know that stress, and I'm not going to belabor this, but growing up in neighborhoods and growing up in families that are poor will make it more likely that kids grow up in stressful environments. And we have to remember that when we talk about poverty, it is the dual risks of family poverty and neighborhood poverty that really compound the effects of those stresses. And these stresses will again increase children's vulnerabilities, particularly when exposed to adverse environments or adverse experiences. The other thing to remember is that when we talk about human development, kids develop with us with this interaction of biology and experience, and it is continuous throughout the life course. It's shaped by the ongoing interplay of sources of vulnerability and resilience, as I said earlier on. And the developing child remains vulnerable to risks, but open to protective influences throughout their lives. Again, as I said, this plays out in the schools and the kids that we see. It's important to remember that the effect of relationships on relationships are the building blocks of healthy development for children. And so children's experiences early on with regards to caregivers will certainly play out as to how they continue to build relationships later on in life. The next slide talks about stress, and I'm not going to belabor this, except to say that the kids that we see when we talk about the social determinants of health, and when we talk about vulnerable populations, we need to understand that the stresses that kids go is what we classify as toxic stress. It is sustained, it's chronic, it's uncontrollable, and particularly if experienced without the support from nurturing, caring adults, may result in dysfunctions. And therefore, oftentimes, again, the behaviors that play out within the context of families or in the context of schools, oftentimes the behaviors are seen as inappropriate or negative, when in essence it really is behaviors that are marked by poorly controlled or overreactive stress responses that are maladaptive, but certainly appropriate given children's life experiences. And so in the lives of children and youth, it is a relationship with adults in their lives and with their caregivers that determine how readily those stresses are buffered. And the relationships children have with their caregivers play a critical role in regulating the stress hormone production during the early years. Insecure, disorganized relationships lead to higher stress hormone levels, and probably the subset of kids that we see and that I see within schools are the children who go through the foster care system. Sensitive, responsive caregivers can buffer elevations in cortisol and subsequent stresses. So I want to talk about school-based health because that's what I do. We know that all children and youth are more likely to succeed in school when they feel safe, valued, and connected to caring adults and their peers. And what happens in schools with regards to relationships and with regards to feeling connected is what plays out in their lives at home, in environments, and certainly being connected to health caregivers makes it more likely that kids are going to follow through on health behaviors that we promote. There is this entity called the Millennium Morbidities. We've been talking about the newer morbidities for a few years. Essentially non-infectious entities that are sort of dictated by the determinants of health and fairly complex societal changes that have been taking place. And the Millennium Morbidities have been added to that as related to and building on those inequities. It relates to violence and abuse that children are exposed to. Mental health is one of the bigger emerging public health issues that we're facing, obesity and teen pregnancy amongst others. As I said, mental health mental health problems in kids are certainly on the rise. 1 in 5 children have a mental health disorder, and it's estimated that about 2/3 of children or youth are in need of mental health services receive the supports that they need. And so when we established our school-based health, we looked at various models and we looked at the history of school-based health and how it has evolved, particularly in the United States and in Canada. And we looked particularly to an organization called the National Assembly for School-Based Health in the US and looked at how they organized their school-based services. And before I go any further, I want to just briefly state this, that when we talk about school-based health, it's important to understand the collaborative nature of school health and to understand that we do it or we exist on a continuum with other existing services in communities, and that we're certainly not trying to replace any services. And that's important. School-based health, particularly in the US, and I think even in Canada now, has been established to try to provide access and to try to provide services for those vulnerable populations that we've been talking about this morning. And one of the concepts of the school-based health centers is this notion of having children attend what is called a medical home, and it sort of relates to the last slide that Dr. Siddiqui had showed in her presentation. That the school-based center becomes the hub of not just clinic visits, but certainly advocacy for a variety of reasons around the child and the family. School-based health centers tend to be comprehensive in providing primary healthcare services, particularly mental health services. When one talks about school-based health, we really do have to talk about mental health services. And again, for some of the reasons that Dr. Siddiqui had alluded to earlier on, and also some of what I had said, which is why I belabored some of the points related to stress and human relationships. and then also providing some prevention and intervention services. I'm just going to skim through the next few slides, and the slides will be available. And so I want to sort of focus on the last few slides. I want to focus on how we do things and why we've done what we've done. I mentioned earlier this concept of school connectedness, the extent to which students feel personally accepted, respected, included, and supported by others within the school environment. And again, acknowledging education as a determinant of health. If we are to look at education as a determinant of health and as an important determinant of health, I think it's important for us in health to establish a relationship with the education sector in trying to alleviate some of the health problems that we see as a result of some of the determinants. Schools also provide a natural universal setting for providing a full continuum of mental health services, and again, the statistics for children struggling with mental health issues are on the increase. As Dr. Siddiqui had alluded to earlier on, good education predicts better health, and ill health or health is both direct and indirect effects on school failure. Inequities in health are closely linked with inequities in education. When we look at why students drop out, a lot of it has to do with academic failure, lack of school engagement, as I spoke about earlier, but certainly life events and those determinants that we talk about, and also problem behaviors. There are certainly classroom or school risk factors that predict school dropout. There are also issues such as mental health, behavioral disabilities. Certainly kids that come from minority households tend to drop out. Children who drop out of school, the association with crime is much higher. And also productivity in terms of the economy and for society is affected negatively with higher school dropout rates. There are also social factors that relate to dropout or school dropout, and poverty is sort of the determinant that underscores all of what I've said. I'm just going to gloss over these slides, and then I want to talk a little bit about school. So opportunities in school, the reasons we're in school. Kids are in school, we can do observations of children in a natural setting. We can reach out to youth, particularly with internalizing disorders, and we are able to provide the 3 tiers of service based on the public health model, so universal, selective, and indicated interventions. And we are and work as part of a multidisciplinary team involving school staff, families, and youth. In Canada, and certainly in the context of Saskatoon, we are able to provide access to care in urban areas of poverty, and that is Saskatoon's core neighborhoods for us here. We can impact and certainly provide access to care for Indigenous communities and some of our newcomer populations. In Saskatoon, school-based health was established to address some of the health disparities that were revealed in our health disparity report. In addressing health equity and children's rights, we are able to level the playing field by providing services within the community, within environments where families and children feel more comfortable. As I said, access to care is a huge issue for people who are socially excluded based on some of the determinants of health, such as race, ethnicity, being poor, or poor level of educational attainment. And then the school-based clinics are within the community, within schools. It's collaborative, integrated, and multidisciplinary. In Saskatoon, we exist as a partnership, and I want to sort of paraphrase a quote by a pediatrician from the US, Dr. Jacoby, who was passed on, who had said that if we are to remain relevant in the lives of children, we have to partner with other organizations and with other agencies. And so when we established school-based health here in Saskatoon, we established the relationship or the partnership with the Catholic School Division as well as the Saskatoon Tribal Council. The Department of Pediatrics, our role in schools is to provide some sort of social accountability to more vulnerable populations. We do a lot of advocacy on behalf of our patients with regards to interventions with their health, with regards to housing, with regards to early childhood development, and particularly within the foster care system with regards to placements. We also teach within the College of Medicine, both within undergraduate program and postgraduate programs in different colleges. The Saskatoon Tribal Council was a very important partner to bring on board, acknowledging the health and well-being or lack of health and well-being of Indigenous populations, acknowledging the history and politics and inequities that have come into play with Indigenous populations. The Greater Saskatoon Catholic Division gives us space to provide health care. Being in schools really enables us to, as I said earlier on, level the playing field with regards to the power differential that exists between us as healthcare providers within tertiary care institutions and patients who come from vulnerable populations. It's a safer space for people to seek out medical attention, or for families to do that and for children to do that. The other important thing with regards to the school, I think the school is the perfect place for other sectors, for the confluence of other sectors that impact the health and well-being of our children. We don't, or as a healthcare sector, we don't own health. The health is influenced by 5 other sectors, and that is education, the Ministry of Social Services, law enforcement, and justice, in addition to health. We're currently in three schools, 4.5 days a week, and we do and provide a variety of services. So we see patients in clinic, but we do case conferences within the community. We do a lot of outreach, teaching, and advocacy. We also have a variety of other services that are part of our clinic. So, for example, we have mental health therapists, we have a clinical social worker, and a psychologist that work with us. We have an optometry clinic, we have exercise programming, we have a respiratory therapist from the asthma, from the Lung Association that works with us. And so really looking at a model of care that is multidisciplinary and collaborative. The slide that I have up there really just gives a snapshot of some of the kids that we see within the school-based practice. And this may be some of the presenting issues, but obviously going through the histories with children, we tease out a number of comorbidities. And so last few slides essentially sort of to just solidify what schools and how the role schools can play in the health and well-being of children is really a place that is community-based, that provides integrated and collaborative models of care, and that really brings the concept of the medical home to the fore. It serves as a link between families and schools, particularly since education is such an important determinant of health. One of the roles that the adults in the clinic, and not just as the pediatrician, but anybody who comes through the clinic who provides services, one of the roles that we would take quite seriously is a role as mentor or model for the kids that we see, and provide that unconditionality that we know that children need within relationships in their lives. The recognition of the role of other sectors and as contributors to poor health, and so bringing those sectors in, and as I said, integrated and collaborative services. And so in a nutshell, what we do is provide accessible services through the schools and the community by engaging in other sectors. Schools are an essential partner in cross-sector collaboration in addressing children's health not just the medical stuff, but also the mental health, behavior, and developmental issues that we see that particularly presents in classrooms and really oftentimes makes it difficult for children to learn. Predictors for dropout are things such as absenteeism, poor behavior, and academic performance. And we see ourselves as being able to impact absenteeism and particularly behavior if we are able to work with kids and understand the stresses that they live with. As I said earlier on, oftentimes children and youth that we see, and particularly vulnerable populations, they often receive services from 2 or more public health agencies. So it might be child welfare and the juvenile justice system, or special education, and oftentimes these services are fairly disjointed. And again, schools provide a good venue for us to sort of consolidate those services in a more cohesive manner. And so in closing, I would summarize what I said by saying that schools provide a location for more coordinated care, and not just for the individual, but certainly for families as well, in the protective environment of a school, which is identified by the community as being safe. It's within the community in a less restrictive environment. It provides a space for the confluence of the sectors that I spoke about earlier on. And again, as I said earlier on, you know, it really is important for us to establish relationships and partnerships with other sectors and agencies. We can work with the schools to reduce risk factors and enhance protective factors, and certainly help advocate for the rights of children, protecting the standards of care, their standards of care, and their right to standards of care, recognizing, intervening, and treating children as they need to. And I'm going to end with that quote. Thanks.
All right, thank you very much, Dr. Mehtar. We did have a question come in from Jennifer asking, will the Saskatoon School-Based Health Center initiative be expanding to any other schools?
You know, that's a good question, and I would say yes, I would love for this model to expand. It's about buy-in from agencies and from ministries. To go back to what Dr. Siddiqui had said earlier on, we have to just intuitively buy into this notion that the well-being of children are important, and so what we get asked all the time is to produce numbers, and certainly in the 7 years that we've been here, we have stats to show that, you know, we see patients in increasing numbers. We have a steady increase in the number of new patients that we've assumed, and certainly our follow-up rate is really quite good. Long-term effects is what we want to look at, and that's going to take, you know, a number of years to actually see our impact in terms of absenteeism, you know, decreasing the dropout rate for schools. So it's trying to convince ministries that school-based health is a good alternative and a good alternative model to care as part of a continuum with the tertiary care institutions. And we're making small gains, and so yes, I hope we're going to be going elsewhere.
All right. Thank you for that. Sorry, go ahead, Dr. Dan.
Can I add to that?
Yeah, absolutely. Yeah.
So the question asked was, has the Saskatoon model, is it going to expand to other schools? I think Miriam has talked to expansion to other schools in Saskatoon and Saskatchewan, but it's clearly extended to other schools in other parts of the country. There are many different places that are now having pediatricians and other healthcare professionals embedded in the school system at least part of the time. In Winnipeg, there's certainly an active group, and in Toronto, there's 3 or 4 different parts of the city that have active groups involved. Is it enough? Nowhere near enough. Is it cost effective? I think this is still to be seen.
All right. So again, my opportunity to remind the audience to type in any questions that you do have into your question box. We did have a few questions that came in right near the end of Dr. Siddiqui's presentation, and we can go back to those now and start the discussion. So Joey has come in with a comment and a question. He's saying, the population level examination of child health is obviously compelling, But he goes on to ask, is there an understanding of how higher risk children contribute to Canada's overall performance in child health, particularly maybe thinking of the UNICEF report? He's thinking in particular of the woeful state of our mental health services, and in particular, the negative impact of maternal mental illness and addictions on child development due to lack of effective interventions.
That's a great question. And what we know in general is that high-risk kids and high-risk adults, the sort of populations you mentioned, are high risk in large part because of what's happening overall at the population level. In other words, it's difficult to tease apart the issues of high risk and populations because they all seem to be part of the same continuum, so that when high risk moves up and down, gets better or worse, it tends to do so in part because entire populations are shifting better or worse. So we see that, for example, with low birth weight. I can't say that I have an example offhand for mental health, but I suspect that it's a similar situation because it's this way for so many outcomes, where low birth weight obviously is a high-risk group, but low birth weight seems really to be a function of the distribution of birth weight, so that attending to high-risk populations and to the sort of overall population, to high-risk groups versus sort of the overall population phenomena tend not to be competing prospects. And from an intervention perspective, what we think is that there are particular interventions that should be focused on children that are at highest risk and parents who are at highest risk, but that we spend so much time on that perspective that we're losing the broader population context out of which that risk evolved. And so rather than think of either or, the population perspective is in part intended to highlight that sort of broader context and to show that there's actually a whole other set of strategies at the population level that we should probably engage in as well.
So you bring up a very important point there, and that is that the question and Arjuman brought up the issue that mental health is probably one of the number one or number two issue that is not adequately dealt with in our systems. Developmental pediatrics and mental health sort of go together as a continuum, if you will, or an interaction between the two, and we don't have the resources we need for that.
I would, one of the things that I would sort of reinforce is that working in schools, probably 95% of the population of children that we see present to us with a mental health, behavior, or developmental concern or issue. Wow. And so the schools is actually, I think, the ideal place to be addressing mental health and developmental disorders or issues. We certainly tease out everything else, but that is the number one reason why I see any patients. And so we really, which is why we've actually brought on board a clinical social worker and a registered psychologist that works with the clinic. So this is sort of the collaborative nature that we work within. Probably about 60% of the kids that I see go through the foster care system, and so that population of children alone struggle with a disproportionately high burden of mental health problems. But the schools is the place to really, I think, establish good mental health services. And I think in many places it exists, but we certainly have built on that existing structure.
And Dr. Mehtar brings up another important point, which is that if the burden of outcomes is so high, if the proportion of kids is starting to get so high, it's really difficult to think about high risk without thinking about the population context. So this is true of obesity as well. It's sort of difficult to subset a small group of children because it's such a widespread phenomenon, even though it's such an intense phenomenon.
So, Mariam, you're head of your training program in pediatrics. how do you think we should alter the training of pediatricians to make them, us, more sensitive to the mental health issues? Because we tend to pick them up and diagnose them not too badly, but then the passing off or the dealing with them is much more difficult.
I think we need to train our residents better. That's the first thing, and I think we need to establish developmental pediatrics and certainly child and adolescent psychiatry rotations have to be. It should not be optional. If we look at how important child development is and how that plays out in how kids develop and how their mental health plays out in later life, I think that's one of the things that we have to do. And I think we have to expose our residents and even medical students at an earlier stage in their careers to more diverse populations and alternative models of care that incorporate mental health or good mental health practices. And I think that allows us to train people that are more likely to look at mental health as part of when we screen in patients in pediatrics, or no matter where you practice, then it just, I think it would alert people more to some of the issues.
Doug, you have the next question?
Well, actually, Joey came back with what he calls his counterpoint, is he's wondering, in some cases at least, if some have reached a saturation point with general population public health measures that leave these residual high-risk populations that won't benefit from generalized policies but require relatively intensive individualized responses.
I can say the answer to that is yes. So, and it's actually the reverse proportion in most cases, that we spend most of our time on intense specific interventions and very little on generalized population strategies. But clearly, the lack of progress, even within particular populations, suggests that the strategies being used that are intense may not be the most efficacious. Not everybody's getting Dr. Maytar's sort of expertise and system. So it's actually, for the most part, it's the opposite. It's that the focus really is not on population strategies. We have very few true population strategies. So they are of no threat, really, to the high-risk strategies. We're sort of struggling to get anyone to pay attention to the fact that there should be population strategies. But absolutely, that's not to the exclusion of intense interventions required for particularly vulnerable populations.
All right, thank you. All right, we'll move on to the next question, and this has come from Gwen, and she's asking, on the issue of the education of the parent being a critical determinant of the child's current and long-term health, how do we think about immigrant families that come to Canada that are highly educated from their home countries but find economic struggles when they get here? Is there any data on whether their education has a protective factor, even when under economic stress in the new country?
Dennis, do you want to say something, or Miriam, or should I?
Why don't you start?
Okay, that's a great question. So there's many kind of ways that sort of family socioeconomic status is produced, and what you ask is a good but very complicated question. On the one hand, we have this phenomenon of immigrant parents who are highly educated but aren't getting the returns to their education in terms of income. And the question is, on the other hand, what do their child health outcomes look like? The short answer is we don't know very well, but the longer answer is that the evidence suggests that their health really is compromised by the lack of income security in particular. That is sort of a fundamental component of the kinds of resources children need to live and thrive. In other words, one major function of parental education is not knowledge per se, but it's the actual kind of material resources that accrue to people with higher levels of education. On the other hand, because parents have high levels, some immigrant parents have high levels of education, it can buffer certain aspects of the experience. So perhaps parents at a more micro level are able to sort of engage with the system better if they, certainly, especially if there aren't language barriers, they're able to kind of think through different strategies to make up for basic resources. But at the end of the day, there's sort of no substitute for the basic socioeconomic resources that should accrue at least to higher investments in education.
I think one of the issues is that we often don't get the information that we need from families, or people don't ask the right questions to find out what their background is. There are some assumptions made up front that put everybody in the same bucket, if you will, which is the wrong way to go.
That makes a lot of sense, yeah.
There. I was just saying that we are just about to the end of our time here, so if anyone does have any last-minute questions that they would like to type in, please get them in quickly, and we'll try to answer maybe one more before we're out of time. And
can I make a comment while we're talking?
Absolutely. Yeah.
You know, there are certain things about our healthcare system which have become immutable. Number one, we walk around saying this is the best healthcare system in the world. Number two, we don't want to change it in any way that's going to wreck it. And three, south of the border, things are quite terrible. And for the most part, we're highly resistant to change. What's happened in parts in the United States is that because things have been so bad, healthcare systems have joined together and brought up different resources, practices and resources to form a system of their own. So those who are uninsured get terrible care, but those who have decent insurance sometimes get a well-orchestrated sort of basket of services that serve them well. And I think we can learn some of those things not only from Sweden and Norway and other places like that, but from places around us that have managed to accomplish that.
We did have one last question came in, and Susan's asking, how can we encourage alignment of public health budgets with the social determinants of health and early childhood research?
So I think the point that we need to make is we need to keep knocking at the doors of those multiple ministries that Miriam was talking about, that are really integrated when it comes to the best outcomes for children. We have to keep knocking at the door until the message gets through, because the message in sort of between election bites is insufficient to do good things for children over the long haul.
I think that's absolutely right, and I think one thing that's a really key point to drive home is that things like social determinants are at the root end of almost every single mechanism we know that leads to child health. It's at the root, it's the root cause of parental environments. It's the root cause of behaviors. It's the root cause of epigenetic and stress processes, physiological processes. So what tends to happen is I think we put a lot of funding into particular mechanisms, hoping that investing in changing child behaviors, for example, which is often the model we use for tackling child obesity, or changing X, Y, or Z pathway will stave off poor outcomes for children. And at the end of the day, what happens is that they don't, because the way that social determinants function is to tackle, as I said, sort of work on every mechanism. So if you block one, they're just going to work through another one. And so I think part of the message has to be that the root causes are these determinants. And so without addressing those root causes, it's a really difficult prospect.
Can I make a couple of points in closing?
I think Dr. Mehtar was just trying to make a comment there, so maybe we could get hers before we do that.
Please.
Thanks. I just wanted to reiterate what both of you said. I think that, you know, the solutions are fairly simple, and I think that they are you know, things to be done, but we have to make sure that whatever we do, whether it is public health measures on a more universal scale, that it is relevant and comprehensive in the lives of children and families. And then when we roll out programs that are more targeted, we have to understand that it is really about relationships that we establish with people, whether it's in healthcare, whether it's in the education sector. We have to, if people trust us to do what's in their best interest, we're more likely to get buy-in, and that is across the board. It's a generalization, but it's something that I think is driven home to me every day that we practice, and I think in all of our, wherever we work, we know that, but somehow or the other we have this notion that because we, certainly in health, we belong to health, that it's automatic, but we really have to work at it.
All right. Well, I think maybe this is our opportunity to maybe wrap this session up. So maybe we could go to you, Dr. Danneman, for some closing comments.
So I thought today's session was very good. I thought the other two speakers were quite outstanding, and I was privileged to be on the same program as them. So thank you for coming, Arjumand and Miriam, and I hope the next two will be as dynamic as this one. I had the privilege of being on the Healthy Kids panel of the Ministry of Health of the province of Ontario, looking at how to decrease childhood obesity by 20% over the next 5 years. And after meeting very frequently, we came up with 3 areas which sort of fit into the whole area of social determinants of health for children. It's basically the first umbrella are those issues that fall under maternal health, from pre-pregnancy to breastfeeding and attachment. The second one is early childhood development into the preschool and early school years. And the third one is the societal overrider. And what was clear from that group as well is that you do need the treatment programs that not only what we talked about here so far of prevention, but you need those therapists who are able to deal with the people at the far end of the spectrum of severity, such as mental health in the case we were talking about, or very morbid obesity in the case of childhood obesity. And I think that sort of model fits both single outcomes such as obesity, but much more global ones because of the interaction between all of those and mental health issues as well. So thank you very much, and I hope the audience enjoyed it and will join us on the 26th of March for the next one. The Paediatrician is child advocate and child protector. Thank you very much.
Thank you.
Yes.
Thank you.
Thank you, Dr. Danneman and Dr. Siddiqui and Dr. Mehtar. It was a great presentation. I'm quite sure you can, as I can always tell by the engagement in the discussion at the end. So that's always a great sign. As we mentioned, this is part 1 of a 3-part series. The remaining parts are up on your screen there. The next one being March 26th. Again at 11 a.m. Eastern time on Wednesday. Registration is open for that session. We will have within the next few hours, I think, we will have some more details about that session up on the site with the speaker names and descriptions as well. Same thing for the 3rd part, which is about vulnerable populations and Aboriginal health. We will have more information and a registration link for that coming soon. That 3rd episode is on April 9th, so we do have a bit of time to get that out to you. As we mentioned at the top of the webinar, we did record this webinar, and it will be made available on the CAFC Knowledge Exchange Network. Those of you who registered for this email with an email address will receive a link directly to that in the next couple of days. It usually takes a couple of days to get that up there. And otherwise, we hope to see you on our next webinars, as we always do these webinars Wednesdays at 11 a.m. Eastern time. So we do hope to see you on the next one. So thanks again to the audience and to the speakers for joining us. And also thanks, I forgot to mention, thanks to the Pediatric Chairs of Canada for